Hello and welcome to this week's Indie Sage briefing. Now, after today's numbers and updates on COVID in the UK, we'll be focusing on the vital issue of creating healthcare and support services that can cope with future shocks of pandemics like COVID-19. This briefing is a collaboration between Indie Sage and Keep Our NHS Public. It was the brainchild of Professor Val Curtis, who took part in the behavioural subgroups of both Sage and Indie Sage. Sadly, Val died around this time last year, but members of Indie Sage have pledged to bring Val's work to fruition. You can read the full report on the Indie Sage website, independentsage.org. Now, before we go on, let's go over to Dr. Christina Puggle for the latest numbers. Christina.
So, right, I'll try to be reasonably quick today, so I hope you guys can see that. So I'm just going to go through the key bits of vaccinations, cases, hospitalizations and deaths, and then I just want to finish a little bit on the Immensa scandal, and the fallout of that has continued this week. So on vaccination data, here's a chart of the overall status in each of the home nations. We've now added boosters into this. You can see, I guess, immediately that Scotland and Wales are doing the best in terms of progress. Northern Ireland is quite far behind in its booster programme and also has the highest proportion of people unvaccinated at 30%. And I just wanted to focus on the rollout in teenagers. So this is 12 to 15-year-olds here on the left and 16 and 17-year-olds on the right. There isn't any Northern Ireland data for 12 to 15-year-olds, so we don't have that. But you can see that England is really far behind Scotland and Wales. Only 21% of teenagers vaccinated so far, 12 to 15-year-olds vaccinated so far, and that's even after they opened up the walk-in clinics a week ago. So in the last bit, you've only increased that by 3%. So unfortunately, that's not going up nearly as fast as we hoped it would. And we're also further behind in the 16 and 17-year-olds, as is Northern Ireland. If we just look at the number of doses given every day, you can see here, this is the booster programme, and that is now accelerating. But we're not giving anywhere near the total number of doses a day that we were regularly doing between March and June. And we really aren't increasing the number of first doses. So if you just kind of take current rates of vaccination and project outwards until we've covered everybody eligible. At the moment, if we assume current rates, we're not going to finish boosting the 9 priority groups or giving teenagers their first jab until the end of February. And that's assuming perfect uptake. If we could double that, we could finish by Christmas. And part of it will be organisation and logistics and supply, which has been a big issue in teen vaccination, but part of it is also demand. So somehow we need to improve uptake. Otherwise, we're going to be in a bit of trouble because, in England particularly, we're relying almost entirely on our vaccination programme to protect us from COVID. We're not really doing anything else. So we really do have to speed this up. In terms of cases, this is overall confirmed cases in the UK up to yesterday. You can see that since the kind of 22nd, 23rd of October, cases have come down. And if we look at that by date of tests in each nation, this only goes up to the 23rd of October, so last Saturday. You can see cases starting to drop in Wales, but still extremely high, flatter in England and flat in the other nations. But positivity rate, so the proportion of people testing positive, is a little different. It's incredibly high in Wales, but falling, going up in England to almost 10%, over 10%, flat in Scotland and coming down in Northern Ireland. And the thing is that yes, cases have started coming down, but it is half term. And if you look at the number of tests done every day, so blue is PCR tests and brown is lateral flow tests, which are the rapid tests you can do at home. You can see that they have really kind of fallen quite a lot since the end of last week, which is the beginning of half term in most places in England. We had exactly the same dip in half term in summer, and we're now got the same dip in half term in autumn. And we're seeing about 150,000 fewer lateral flow tests today compared to a week earlier, and about 20,000 fewer PCR tests. a day. And if you kind of project that with their relative positivity rates, that's about 4,000 cases that are probably missing just because we're testing less. And that's not all of the drop. I think there has been some real drop, and we'll see that in a minute. But definitely, you know, the current dip, a lot of that is just half term. The ONS infection survey came out today. The age thing is still quite shocking. You can see that up till 22nd of October, so the end of the first half term, that the secondary school children under 16 still going up 9.1% were infected that week. 4% of primary school children were infected that week, and that is still twice as high as the previous peaks back in December. If we look at new cases that were recorded by different ages, you can see that actually it looks as if cases in school-age children have peaked for now, reported cases over the last week of the last half term, but not yet for the adult age group. So maybe in their parents' age group, but not yet in even the older age groups. And it's a bit hard to know what's going to happen with adults. I do think that half term is going to make a difference. In that it was a lot of children were driving infection, they are now not mixing. It will slow down transmission, but they are going back to school with actually not that high a vaccination rate yet. But adults have an issue in that there is some waning immunity now in many adults. So even though cases are dropping, they're also becoming a bit more vulnerable until they can get a booster. And we also just had a new study released yesterday showing that household transmission is actually really important. That if you're fully vaccinated, although you're less likely to get COVID and much less likely to get very sick from it, if you're living with someone who has COVID, you still are actually quite likely to get it. And you're also quite likely to pass it on to someone you're living with. So household transmission has become really important in this kind of highly vaccinated age. Hospitalizations and deaths. Well, in line with cases, hospitalizations are increasing quite a lot in Wales and in England too, coming down in Northern Ireland. They've actually just started increasing in Scotland, which is interesting. But if you look at the age data in Scotland, what's happening is that cases are dropping a lot in school-age children, but they're going up in older adults. And this is now translating through to hospitalizations, even though overall cases aren't going up. In England, hospital admissions are back to as high as they have been since the winter. And I think 911 was the most recent number. And because we've still seen cases increasing in adults and older adults, that's unfortunately likely to continue. And that's why I think Patrick Balance yesterday said we're actually in a very precarious situation. Even if we don't need cases to keep going up, we just need, unfortunately, adults to keep getting infected to create strain. And we're kind of seeing a similar picture in deaths, is that we've had, you know, well over 100 deaths a day for a very long time now, but that's now starting to creep up. And so we've just gone over 1,000 deaths reported in a week. And because of the recent rise in cases, this is likely to keep going for a couple of weeks yet. But we have now boosted about 50 to 60% of over 70s, and that might actually put a brake on deaths rising. I mean, I hope it will. And then just to kind of finish on the Immensa scandal. So last Friday, we released a statement calling for a lot more transparency and some urgent actions on the back of it. And I just want to kind of highlight what's kind of happened since then. This is the number of weekly cases per 100,000 for English regions up to the 23rd of October. And the Immensa kind of false negative thing happened between the 2nd of September and the 12th of October. So this time, and you can see here, this is the region that most affected was the Southwest. And you can see here this big dip as they were getting false negatives. So actually we weren't reporting them as positive when they were, and people went out on mixing. And since then, really transmission in the Southwest has taken off. And even though here it has just started to fall in the most recent days, the positivity rate has also done exactly the same thing and is going really high. And this isn't just about people coming forward for testing once they heard about the scandal. The ONS infection survey today also now shows that the Southwest has quite a lot higher rates of COVID than anywhere else in the country, and this is based on random sampling. And it wasn't equally affecting all places in the southwest. There were 13 local authorities that were particularly hard hit by the scandal who sent their tests to the lab. So we can just look at the cases in different age groups, saying this is 10 to 14-year-olds and local authorities most affected versus all other local authorities in England. These are the local authorities affected. And you can see here in the red line just quite how dramatic that increase was in 10 to 14-year-olds that has now in the last week just starting to come down. But if you look at their parents' generation, the 30 to 59-year-olds, it is still going up and is still incredibly high, almost 1% getting infected every week of that age group. And you see a very similar pattern in South East Wales, where it was also really badly affected. And we've had loads of stories this week about conditions at the lab. There was a story about whistleblowers revealing it was really chaotic and dangerous working conditions at the lab, people who were untrained, kind of doing tests and not being properly supervised, and no real quality checks. The First Minister in Wales has told the BBC and just at a press conference saying that he thinks one of the problems in South East Wales is because of the Immensa false negatives. It also came out that Immensa has also been awarded a contract in September for £12 million to process PCRs on COVID variants. And it's just generally an issue in that the English government is saying there's been no impact from this, and they're kind of defending the lab as opposed to actually, I think, trying to defend the citizens who've been affected by it, particularly in the southwest. And in general, beyond Immensa, there's a story that came out this week that actually thousands of tests are not going to be processed because all labs are suffering from supply chain problems, and this is causing a real issue. The Financial Times, this is actually a story from August, but was actually then pointed out that most private labs processing COVID tests, a lot of them actually for travel, not for NHS test and trace, are not accredited. We know that Immensa wasn't accredited. What we need to know urgently is what other labs running NHS tests are not accredited, and are there similar problems happening there? And if you think about with COVID tests, you can get a positive result or you can get a negative result, and you can also get what's called a void result. And that can happen for all kinds of reasons, but there's kind of reasonable reason to believe that the more stressed the lab is in terms of too many tests and not enough people to run them, the more likely you are to get a void result. And so you can track the proportion of void results over time and see what's happening. And if we do that for England, this is the percentage of PCR tests that return a void or an unknown result where the test is just lost. This is the winter peak, and you can see during that peak there was a big increase in the percentage of void PCRs. Then everything came down. As cases came down, there was not stress. This is actually the Euros, where cases went up rapidly, and you can see the percentage of voids increased, although they weren't that high. But since September, we've really seen this massive increase in the percentage of void tests. And it's kind of thinking, well, some of that might be Immensa, but if you actually look at it regionally, it's happening everywhere. And so it looks like there might be, this might be another kind of consistent measure saying that there is real stress in the testing system. So just to summarize, the most recent fall in cases is likely due to a combination of reduced testing and cases starting to fall in school-aged children, but they haven't been falling yet in adults. I think half-term will have an impact in further reducing cases, particularly in school-aged children. You are breaking chains of transmission, and I think that will lead to some continued reduction, at least in those age groups, for the next couple of weeks. But what happens on return to school is still uncertain, because yes, there is unfortunately now quite a lot of immunity from infection, but we really haven't got very high vaccination at all, and that isn't giving us the buffer that we could have hoped for at this point. Valence said yesterday that we're in a precarious situation, particularly with hospitalizations rising, and I think that stays the case. We don't have to go to 100,000 cases a day. We don't have to get anywhere near that to be in a precarious situation. And I think finally, we urgently need more clarity around the Immensa scandal. You know, what happened, what is happening to prevent similar elsewhere, and how are the communities affected going to be supported in the future? And I will end there.
Christina, thank you very much indeed. To kick off the briefing, Professor Rob Alger, Val Curtis's husband, will say a few words about Val and her vision. We'll then bring in 3 other panelists for a discussion on the issues that he raises. And then finally, we'll go to our usual question and answer. So Rob, over to you for a few minutes.
Great, thanks for having me. Val Curtis spent nearly 30 years of her life at the London School of Hygiene and Tropical Medicine, promoting hygiene and sanitation in countries outside the UK. Basically, she made hand washing with soap, which has become such an important issue, an international public health issue, starting 30 years ago, culminating in her work to get a sustainable development goal for hand washing. She was also a scientific advisor to what we thought of at the time as the most grandiose behavior change project in the world, which was Swachh Bharat, or the Clean India campaign, which was designed to get a toilet into every household in India and was largely successful. She eventually became the leader of our world-class group at London School on hygiene, environmental health, and took the role very seriously, even taking leadership classes to understand how to be more effective. Although basically anybody who ever met her was able to remember that event. She was a very passionate individual, and her colleagues affectionately called her the Queen of Hygiene, which I think was an appropriate title. In her final year, she switched gears to get involved in COVID in the UK, also in other countries, and was most honored and proud to work with a whole new group of colleagues whom she held in very high esteem, both for their intellect and moral vision, and that would be you guys. She also came up against constraints in the provision of healthcare in the UK and wrote an opinion piece in her beloved Guardian about the consequences of austerity policies on the NHS, both for her and thousands of others, which continues to this day, leaving many with a sense that something should be done about the underfunding of this vital public function. It's now 1 year since her death, and I think she would be very happy to see the work that has been done on this issue and which is being discussed today. So I'd like to say thanks on her behalf for your work on this important topic and for considering this to be part of her legacy. Thanks again.
Rob, thank you very much indeed. Very, very great to hear. Now, Professor Martin McKee is going to outline a very brief report from IndySage.
Hey, thank you very much indeed, Alok. So cast our minds back to when the first news arrived from Italy showing intensive care units being overwhelmed. And many people working in the NHS were entirely appropriately really alarmed, because for many years we've known that compared to our Western European neighbours, our health service has suffered from chronic underfunding. We have far fewer doctors, far fewer intensive care unit facilities, and far less advanced medical equipment than countries like France or Germany. When I talk to my colleagues in these countries about winter pressures that we face every year, I often need to explain what this is. Everybody suffers from increased respiratory infections in cold weather, but their health systems can cope, whereas ours struggles. So in the light of this extremely poor performance of the UK during the extremely poor performance of the UK during the pandemic is really hardly surprising. Now, of course, there are other reasons too: a lack of political leadership, the loss of the social safety nets, and the promotion of a gig economy that made it so difficult for people to stay safe. But while other countries were focusing on how to put in place comprehensive strategies to control the pandemic and to limit the economic and social damage, we were preoccupied with saving the NHS. Now, in the end of the day, we did, or rather, the heroes on the front line did. It wasn't the Nightingale hospitals opened at great expense that saved the NHS. In reality, they treated hardly any patients. Nor was it the private hospitals, which again benefited from the lucrative contracts to provide additional capacity. And they too underdelivered. Instead, it was the doctors, the nurses, the other health workers who adapted to new ways of working, often in the most difficult of circumstances. And some, as we know, tragically paid the price with their lives. Well, our statement has a simple message: never again. Of course, there will be further threats to health, and as our regular listeners will recall from last week when I was talking about what we're doing to prepare for this at a European level. But when these threats come, we cannot afford to be unprepared again. So what are we calling for in our statement? Well, we need to adopt policies that reduce the load on the NHS. For a decade, we have experienced stagnating life expectancy, and for some groups, like older people, it has even got worse. And this is almost unique among high-income countries. The US is the exception. And it reflects, of course, the misguided austerity policies that have damaged both our health and our economy. We need to reverse the widening of inequalities that have left so many communities behind. But then we need an NHS that is fit for purpose. Now, this absolutely is not a criticism of those working in it. They are, as I've said, the heroes, or rather, to coin a phrase from a century ago, they are the lions led by donkeys. And in the current proposals to reform the NHS, we can really see little that will make things better and the real risk that it will make things worse. Well, we've identified three things that demand our attention. The first is a focus on effectiveness. Our country faces profound economic challenges going forward. We can expect much lower economic growth than our neighbours, so we have to make sure that the limited money that we do have is spent as effectively as possible. And this means concentrating on the things that matter. We need to be investing in the future, in health as in education and infrastructure. And we need to be giving our population the reassurance that will allow them to look forward with hope. And this means tackling the long-standing neglect of social care. And we need to invest in other areas that have been neglected, such as mental health and support for people with disabilities. And secondly, we need to look at health through an equity lens. We need to ensure that services are provided fairly for everyone, ensuring that wherever they live, they are able to get the health they need with dignity and with ease. And third, we need an NHS that is resilient in the face of the potential shocks. And this means that we must have the capacity to respond to surges in demand. We cannot go on, as we have been doing, asking it to run at 95% capacity. So if we're going to do this, we need a consensus among the public and all of the key stakeholders. And this must be based on the core values of decency, of security, of justice, and of compassion. We need to make the invisible visible, revealing the scale of unmet need in our country and finding ways to meet it. And we need to challenge the myths that surround healthcare. For example, those who say that it is unaffordable, or that private services are always more efficient, or that public health is about individual choice. So following from those considerations, we've set out a 10-point charter for health. It's on our website, so I'm not going to go through it in detail. I just want to pick out, as we close, a few very brief points. We need to restate the evidence that health is a major contributor to the economy. We need to see health expenditure as an investment. We need much greater capacity to respond to surges in demand and the flexibility required in an emergency. And we need to bring together everybody contributing to health and social care rather than creating artificial barriers between them. And we need to invest in high quality services for everyone. Finally, and really importantly, we need transparency and accountability. Transparency and accountability of what, as Christina has just told us in the Immensa laboratory, we have not had. These are two things that have been in far too short supply during the pandemic. So I commend our statement to you, and I will pass back to you, Alec. Thank you very much.
Thank you, Martin. A few words now from Professor Nina Modi on the background to that report.
Thank you very much, Alok. So I'm here today because I had the privilege of being a panel member for the Keep Our NHS Public People COVID inquiry. This was chaired by, this took place, the evidence hearings took place over the first half of this year, and we issued our preliminary report in July of this year, with the full report due out in a short while, certainly before the end of the year. The inquiry was chaired by Michael Mansfield, QC, and we heard evidence from both experts and professionals, as well as members of the public. And in summary, what I have to say is that Val Curtis's report, of course, what we found in the Keep the NHS Public Peoples and COVID inquiry really reinforced and underlined the messages that Val has put together in her report. So I'm going to pick out 6 points from this to show you that the evidence that we heard from experts and from the public really, really underpinned the challenge that she has set. The first is the phrase, protect the NHS. The NHS is here to protect us, but because of the fact that it went into the pandemic so crippled, the public and the workforce were forced to protect the NHS. And as Martin has said, many of them tragically paid for this with their lives. The second point is that it is rarely insufficiently understood that healthcare really contributes only a small proportion, something between 10 and 20% of the health of the nation. The major contributors to the health of the nation, the 80% plus, come from what happens outside of healthcare. And of course, COVID underlined this very, very seriously indeed, because it showed that those who were most disadvantaged in our communities were the ones who suffered most of all. So let us really break the myth that healthcare is the primary determinant of health. Healthcare is important, but we can reduce the burdens on healthcare by paying heed to the health of the population. And we do that by paying attention to the things that determine health. The third point is language. We must stop speaking about health in terms of a drain on the economy, a call on the economy, and a burden. This is an investment in the future and the resilience and the sustainability, above all, of all nations in the world. The fourth point is that we should have wise investment. We've seen during COVID the tragic waste of public monies, most recently exemplified by the Immensa scandal that Christina has outlined. And there are countless more examples of tragic waste of loss of money. And I remind you all of Captain Tom, that valiant octogenarian who walked up and down in his garden. Little did he know the extent to which hard-raised funds through charity and funds raised through taxes were being wasted. My next point is about the workforce. The workforce was not cared for. This came out very, very clearly during our inquiry. And of course, this is the greatest strength of the healthcare and the social care system that we have in this country. People take pride in public service, huge pride. They do what they do, not because they want to become rich. Of course, they want a decent salary, but they do not want to make money out of healthcare. They have pride in public service. And this needs to be recognized and acknowledged with the immense strength that the ethos in this country gives to the nation. It is being traduced by the example that we see, which suggests that money can buy everything and that people are driven only by interests of monetary gain. That is absolutely not the case, and it is exemplified at the NHS. And the final point that I want to make that emerged from our inquiry is that it is legitimate, fair, reasonable, and appropriate for the public to demand competence from their governments, competence in safeguarding the health of the nation, also competence in delivering a health and social care service that's fit for need. But I repeat, above all, competence in ensuring that the determinants of health are paid heed to and that the health of the nation is a primary policy focus. So, Robert, thank you very much. We would all like to pay tribute to Val and her work and to emphasize that the evidence that we heard absolutely exemplifies what she has set out in her summary.
Nina, thank you very much indeed for that. Thank you for everyone for setting the scene for us. I'm going to welcome to the floor now Dr. Tony O'Sullivan, who's the consultant paediatrician and co-chair of Keep Our NHS Public. And Helen, you're there as well. Helen Salisbury and Tony, you're going to ask some questions of our panelists. So take it away, Helen.
Thank you very much, Alok. We're delighted to welcome some expert panelists who are going to talk to us today about how this report reflects what's going on in their particular parts of the health service, and how we might do things better and to kind of look forward, hopefully. First of all, I'd really like to welcome Dr. Helen Calaspi, Professor Helen Calaspi, who's a professor of rehabilitation psychiatry at University College London. Welcome, Helen. And my question for you is, how has the pandemic affected the care that you've been able to offer in your service? And what's your vision for how it could be improved as we eventually emerge from the pandemic?
Well, thanks very much, Helen, for the question. I want to reflect really on something that the Royal College of Psychiatrists president said earlier this week, which is that we're facing the biggest mental health crisis, a mental health catastrophe, I think he called it, of recent times. And I think that apart from the increased demand that the pandemic has brought, of course, we're also dealing with the backlog of the fact that services were effectively paralysed during the pandemic. To give an example, in our own services, all admissions and discharges effectively stopped for a number of weeks. And so the whole usual flow through services just ground to a halt. Of course, that has an enormous impact on the individuals who are in hospital at the time and the people who are working in mental health services at the time. And I think, people are still really quite traumatized and exhausted by those experiences. Currently, services on a day-to-day basis feel as though they are getting back towards normal practice. But as I say, there's a massive backlog and increased demand. Just this week, a paper was published about the vast increase in referrals for early intervention for psychosis services. So we're not just talking about an increase in demand for treatment for depression and anxiety, we're also talking about an increase in demand for more severe mental health problems like psychosis as well. I think in terms of the report, it really highlights some of the challenges that my particular part of mental health services, but other parts have been facing for decades, really. The underfunding that mental health services have experienced means that they've had to manage on very little for a very, very long time. This, places all sorts of challenges to the kinds of care that can be delivered. Staff are often run very, very ragged, often operating on what is effectively quite a skeletal service. And that, of course, has an impact on patient care, has an impact on staff morale as well. It would be great if we could see more investment in mental health. I think the budget this week mentioned figures of around £500 million, about £450 million, that was specifically noted as coming towards mental health services. The Royal College of Psychiatrists has identified a funding gap of something like £8.9 billion. So we're a long way from meeting that. In terms of the impact of the direction of travel towards more private healthcare provision, I see this on a daily basis, the negative consequences of that. And that's not to say that private mental health care is all bad, by no means am I saying that. But when we're talking about people with particularly complex, severe, longer-term mental health problems, what we've seen in recent years is a massive expansion of private sector provision. In 2018, the CQC published a report that showed that for inpatient mental health rehabilitation services, so these are the services working with those with the most complex forms of psychosis, and these are the kinds of services I work with, there are over 4,000 beds in England and Wales, but over half of those were provided by the private sector, and recent data shows very little change in that. So over 2,000 of these beds are in the private sector. And the problem with that is that they're often a very long way from people's homes. They're further away, and that makes it very difficult for people to keep in touch with family and to keep in touch with the local services that are going to support them when they get out of hospital and continue their community-based rehabilitation. And because of those problems, this sort of social dislocation and service dislocation, people end up in private sector hospital beds for longer than if they were being treated locally. And because of that, the costs of care are greater in the private sector, even if the daily cost is similar to the NHS. So the total cost of these 4,000 or so beds was about £500 million a year, but 2/3 of that is absorbed in the private sector. So although I'm drawing attention to underfunding, I'm also drawing attention to the inefficiencies in the current system and how we could actually work much better together to evidence the appropriate place of the private sector in the complex mental health system. And I suspect there are similarities to be drawn in other parts of health, not just mental health as well. I think the other thing I want to say is that we also have seen inefficiencies in social care. People with more complex mental health needs may well need to live in some form of supported accommodation in the community. And I'm hopeful that the Health and Social Care Bill may help us unstick some of the inefficiencies. One of the problems that we've seen and been working with for years clinically is the re-procurement of providers of these kinds of services. So when you're working with people with long-term problems, continuity is really important, building trust and working with people slowly and in a graduated way. And when you have recurrent changes of provider and therefore staff, all of that therapeutic engagement is undone. So I'm hoping that if the commissioning process can put as much or perhaps even more effort into performance management as it has done into procurement and re-procurement, we may begin to see some benefits from working with a new approach. I'll stop there.
Over to you, Tony.
So I'll come in with the next question and welcoming Adelina Comas Herrera. Adelina is co-lead of the Strengthening Responses to Dementia in Developing Countries, STRIDE project, and she's assistant professorial London School of Economics and expert in social care. So Adelina, I've got a question for you. My parent died from aggressive dementia a few years ago. In my job, I'm a retired pediatrician. I worked with families and disabled young people wanting and needing to live independent adult lives. So I see a very wide range of need in terms of care for a national service that can provide care and support also for independent living. And that's not in the NHS, but working together with users of service and with the NHS. So could I ask you, what is your take on this admittedly complex issue?
Yes, thank you. Thank you very much. I'd like to start by sort of taking us back to the beginning of the pandemic, where we noticed just how detrimental and impactful it was, the fact that the social care sector had such little public and political visibility. It was essentially forgotten at the beginning of the pandemic when it came to resources such as testing or even access to PPE. So what we had also was very, very late guidance that was suitable for the sector. But even with this late response, once we had some measures in place, what we were finding is that there were huge difficulties in implementation because of the enormous complexity of the social care system. Basically, it's such a complex system that it was almost impossible to know who is in charge, who was accountable, who had responsibility. And we have had an enormous impact. We have had a huge number of deaths, particularly people living in care homes, but also huge numbers of people who've gone without the care that they need. And we've also had unpaid carers having enormous burdens. We have also had a lot of difficulties to monitor the outcomes and what was happening to this population. We don't have data systems that are able to collect that information. And for example, we have not been very good at understanding what the implications of some of the measures like restricting visiting were having on the people who live in care homes and how that's impacting their mental health, well-being, but also the mental health of their families. So we know we have a problem, and also we know now that we are stepping out of the pandemic with a huge problem in terms of workforce shortages. This is a system used in inverted commas that is very chaotic. It's been years and years of small incremental changes and small reforms. There hasn't been a national settlement a vision for the social care sector. And we have been engaging with stakeholders, including people who live and use services. And we have been asking what they felt was needed. And it's all very much converging towards a new national settlement that addresses these governance issues, that clarifies accountability, that gives a real voice and rights to people who use social care, and particularly those who live in care homes, what are their rights, how can we clarify that we have mechanisms to ensuring that their human rights are respected. We obviously need to address funding, and with addressing funding also have a proper, suitable long-term workforce strategy, and of course a data infrastructure that allows us to understand what is happening. Now, whether that is called a national care service or something else, I don't know exactly how we need to call it, but it does have to be a system, not in inverted commas, but a real system that has a vision and has a real structure and infrastructure attached to it. Thank you.
Thanks very much, Adelina, and back to Helen.
Thank you very much. I'd now like to introduce Dr. Louise Irving, who's a fellow GP in South London and a great health campaigner. And I'd really just like to ask Louise about effects on GP, and particularly I want to know what does GP need, or what do GPs need to do to realise these key values that have come out in this report of effectiveness and equity and resilience? It's quite a big question. I don't know which bit you want to tackle, Louise.
Thank you very much, Helen. And when I read the report, I was reflecting a lot on what these terms, effectiveness, equity and resilience, meant in general practice. And first of all, I'd like to just talk about the general principles of general practice, because they are really in keeping with the report. They are based on the principle of equity. Everyone can register. Everyone living in the country can register with a general practitioner. Even if you're homeless, even if you're a refugee or an asylum seeker, you have the right to register with a GP practice. Now, not every practice is as proactive as the others in promoting that, but it is there as a fundamental right. And I think that's really important. The thing that's really undermining equity is that many general practices around the country have been forced to close. And there are large parts of the country where people no longer have access to a local general practitioner because of what's been happening to general practice over the last decade or so. In terms of effectiveness, we have to remember that something like 90% of healthcare contacts happen in general practice. Now, that doesn't mean that GPs are doing 90% of the work of the NHS. Obviously, that's not that. But it is the first point of contact for many people who believe themselves to be unwell, but also for health promotion, for all the things we were talking about, prevention, but also helping with mental health issues. We deal with a lot of basic mental health problems, such as anxiety and depression. And we look after people from the cradle to the grave. That's really important. And all the research that's been done on general practice showed that it is actually a very effective system. And one of the reasons for its effectiveness has been this concept of continuity of care, where the patient has continuity of personal contact with a general practitioner or a practice nurse or other provider in the practice over a long period of time, with practitioners who actually are embedded in the community and know the community and know the problems the community faces, but also know the services that they can refer patients to. Now, continuity of care has got a very good evidence base, and I know that the declaration talks about evidence-based care going forward. We need to look at this evidence base for continuity of care, because it has been totally undermined continuity over the last decade or so, and GPs are finding it much, much harder to keep that personal relationship with their patients. And I think part of that kind of all the anger that patients were expressing, that was stirred up by the Daily Mail recently about not being able to have face-to-face consultations, I think part of that is a sense that patients do have, that they've lost a personal relationship with their GP and with other members of the team. And that's been going on for a while. The government has been really promoting a different model of general practice, which is much more to do with anonymous, online provision of service from, commercial providers who could be anywhere in the country that you'll never see again. So it's the problems that general practice has been facing have been partly due to underfunding, which has been terrible. The proportion of funding going to general practice overall in real terms has fallen over the last decade, and the proportion of NHS funding going to general practice has dropped. understaffing. We have something like 5% fewer full-time equivalent GPs than we had in 2015, but also an attack on the very model of general practice, the effective and efficient and popular model of personal care. And I think if we were to go forward, we need to actually bring in measures that reinforce that positive model of general practice, which has been eroded. To talk about resilience, I didn't know how to answer this, because on the one hand, I think general practice has shown itself to be very resilient during the COVID pandemic. Our other speaker talked about mental health. All those people increased mental health needs during the pandemic, but decreased access to mental health care means that general practitioners were carrying a larger burden of the need to care for people with mental health problems. I know every day people were phoning our practice saying they were suffering terrible anxiety and stress, worsening of depression and worsening of psychotic conditions too. The other burden was having to support secondary care, because we couldn't get our patients seen in secondary care. Lots of the outpatient clinics had been suspended. So again, GPs carrying that extra burden of caring for patients over time who really needed secondary care input, hospital input. As well as that, certainly we also ran the vaccination campaign, which has been one of the few sort of relative successes throughout the COVID pandemic. And we increased the number of consultations that we delivered by something like 20 to 30%, of which 50 to 60% remained face-to-face. So I think that's pretty incredible, but it's come at a cost. There's definite evidence of increased burnout amongst GPs, and a lot of older GPs are taking early retirement. And even my younger colleagues, I worked in a practice with fantastic younger GPs. They're all really getting pretty fed up. And these are people very, very motivated to provide good quality care. They really love general practice and they love the idea of being GPs. And they're actually getting really, really fed up with it. And so I don't know how resilient. Nothing is infinitely resilient, is it? If it's not supported, if it's not funded, if it's not valued, if it's not properly staffed, it can't survive. And so I think going forward, if we want to have a positive NHS bit for the future, part of it must be to really support general practice and to value it and to make it once again. When I first started as a GP, there were like 100 applicants for every GP post. It was an incredibly popular profession, and it's been an incredibly satisfying career for me to have worked in. There's no reason why it shouldn't become that again. And I'm not just talking about GPs, I'm talking about my colleagues, the practice nurses, all the other health professionals working alongside us. It's potentially a fantastic job, it's a fantastic service, patients love it, it's very effective, it's very equitable, and it could be, it's shown itself to be very resilient, but it certainly needs a lot more support. So I think it should be central to what we're campaigning for.
Thank you so much. Over to you, Tony.
Sorry, I thought you were waiting for me, Helen. Thanks, Louise. Can I just go to Professor Martin McKee now, who everybody knows, of course, London School of Hygiene and Tropical Medicine, and an expert in public health in this country and worldwide, it seems, from all your prolific work. The question from me, the UK's tragedy in the COVID pandemic is that political policies have failed our very wonderful National Health Service and public health expertise of world renown. And as a result, despite all that, we have one of the worst public health outcomes and one of the worst economic failures. So given that, what would you advocate as the way forward for the public health element of our proposed services?
I wouldn't actually separate them. We did a report for the European Commission back in 2005, which looked at the contribution of health to economic growth. Now, healthier people stay in the workforce for longer. They don't retire so early. They also work more hours per week. They're more productive when they are at work. They invest more in their own education and training because they know they'll be able to benefit from it. And for small and medium enterprises, they invest more for their future because they know they will again live to see the benefits. So often we see this idea of health and wealth, health and income, health and money as a dichotomy, which is absolutely wrong. And we've seen that very clearly in the pandemic. The countries that bore down most effectively on the transmission actually have had the best economic situation. So I think we need to recast for the UK audience, because I think this is agreed widely elsewhere, the recognition that investing in public health is good for the economy. Now, as you know, Lou Ham, Danny Dorling, myself and others have over the last few, and David Stuckler over the last few years, have been looking at what's been happening in the UK. We've been lagging far behind other industrialized countries. We've had stagnating life expectancy. It's been going backwards for some people, and in some places, in the coastal towns in particular. And I don't think that we've got this message across in the UK. That's quite different at an international level. And last week I was talking about the Pan-European Commission led by Mario Monti. Now, later on, I think maybe today, but next week, we're later on this, I think today, we will be having the statement out from the G20 ministers in Rome. And they, I think, have bought into this argument very clearly that we need to invest in public health for the resilience of economies, for the resilience of societies. And the international financial organizations, ones that have often not been seen as very friendly to public health, have got it as well. The IMF really recognizes this and is looking at ways of putting health into their Article 4 consultations with countries. Because it's now become clear to these international agencies and credit rating agencies and others that if we do not invest in health, then economies are going to be vulnerable in the face of a future threat. So I think the evidence is there, and we can see it in things like Mark Carney's book, Values, Central Bank Governor, Bank of Canada, Bank of England. You know, that's a public health textbook if people haven't read it. Highly recommend it. Gordon Brown's book, 7 Ways to Save the World, making the same point. So in a way, those arguments have been won at an international level. Whether they have been won in Westminster or particularly in the executive of in the government in the United Kingdom or in England, that's not clear. But we just need to make sure that the more general arguments are being heard here in the UK, and we move away from this English exceptionalism.
Thank you very, very much, Martin. And back to Helen.
And I'd like to ask a question from Nina, if I may, Professor Nina Modi. We've made this report now. What can we do with it? What next steps have we got? How can we have some impact? I wonder if you've got some ideas on that, with both your medical hat on, but maybe also with your campaigning hat on.
Yes, more than ideas. Thank you very much, Helen. So I'd like to approach that from 3 perspectives. One, as a clinician, I'm a neonatal intensivist. So I love sick newborn babies is my clinical specialty, but also from an academic perspective, because I lead a research group, and thirdly, from a professional and as you say, advocacy and campaigning aspect. And so let me take each of those in turn. We've spoken about investment in acute healthcare and community healthcare, mental health care services. We've spoken about investment in public health, but we also need to speak about investment that lies outside these traditional medical domains. Because if we don't get housing right, or air quality right, or water quality right, all of which fall within the public health domain, but are not traditionally funded through public health mechanisms in this country, then we're not going to get public health rights. I can give you an example from my own specialty where despite decades of trying to prevent preterm birth with no success, we have a publication recently out that shows that during lockdown, preterm births and admissions to NHS neonatal units fell significantly for, and this is the interesting bit, for the most disadvantaged sections of our community. Finally, we have a mechanism which needs to be explored further, because we don't know which of the many candidate possibilities led to this, but we have something that has absolutely reduced preterm births, despite years of trying within the health service. So for me, a very graphic example of how the solutions to the problems that we see also lie within the wider health sphere. In other words, government must pay heed to the early life, social, the wider determinants of health. So we can do this from a clinical perspective. We can do this from an academic and a research perspective, but we also need to do it through professional leadership. So I'm delighted to say that I, like many of you, will be linked up with communities around the world, clinical, academic, and professional. And for example, I'm also delighted to say that the British Medical Association will be campaigning. I am the current president of the BMA, and the BMA will be campaigning to make health, population health, human health, a primary policy target, so that we stop having these juxtapositions. For example, with one hand, paying the junk food industries to boost the economy, paying the tobacco companies to boost the economy, and meanwhile, paying the public health consequences of the poor health that these industries bring. So we've got to make human health a primary policy target. We can only do that through bringing together our clinical, our academic, and our professional expertise. So, Helen, I hope that gives you a flavour of how we can give this report traction, and indeed the evidence that emerged from the Keep Our NHS Public People's COVID inquiry, and how absolutely we can pull together to make this happen.
That's fantastic, Nina. Thank you so much. We have, as always, gone a little bit longer than we expected, but we've got time for one or two questions, which I think have come in from listeners.
Yeah, that's right, Helen. Thank you very much for all of that to all the panelists. That was really, really interesting conversation. We do have a few minutes left for questions that have come in. Let's start with this one from Sophie Sweetman. How can communities and healthcare providers work together to ensure that everybody can access evidence-based health information to improve the nation's health and ensure private interests are not influencing public health information and policymaking? It's a very complex question. And just for the sake of being finishing on time, I want just one person on the panel to answer each of these questions, if you don't mind. Who would like to take that one? How can communities and healthcare providers work together to ensure everyone can have access to evidence-based health information to improve the nation's health? Put your hand up. Is there anyone who'd like to tackle that one? Without stand you into silence. Anthony, yes.
It's a very big question and difficult to answer. I mean, there's, GPs are extremely busy, but they are the focal point of their local community. And there have been a lot of measures moving beyond the provision of just care to preventive health, social prescribing, and the like. But I think we need to rethink actually the amount we spend on public health budgets, particularly in relation to health promotion, to, helping people to get access to tools or meetings or groups that help them to relax, to eat healthily, to move, to sleep well and the like, all the kind of preventive things we want. And that needs a much bit. I mean, the amount of spent on public health is tiny in this country. And just to add that if we're constantly bombarded by media saying, oh, all these huge bloated health service. We spend less on health. I was looking up the figures than Ireland, than Germany, than France, and the United States spends 2.5 times what we spend on health. So, there is scope for improving the preventive component. And we should remember what the WHO says, health in all policies. And I'm involved in a program called Children in All Policies. And if we just look this week, we have cut by 18% the incomes of the poorest people in the land. Those are people on universal credit who are not working. And that's 2.1 million citizens in the UK. And that political decision means we will have debt, stress, and hunger this coming winter. And so when people say medics and scientists shouldn't get involved in policy, I think they should, when we know that political decisions will lead absolutely to deprivation.
Okay, Anthony, thank you very much. Okay, so one more question, I think, before we go. The report makes the claim that we need to rethink the economics of healthcare and put it on the credit rather than the deficit side of the balance sheet. Do you think policymakers and the public will buy this? And I've got a note here that Professor McKee is good to answer this one.
Well, I guess so. And as I say, I think we'll be seeing the arguments in the G20 minutes, the G20 statement that will be coming out. And it is the arguments are set out very clearly in the report of the Pan-European Commission. So I think I sort of answered a bit of that earlier. I think we're pushing at an open door, because I think ministries of finance and ministries of and heads of government are very much seeing that. I think we are likely to hear an announcement about a global health finance board later on. I shouldn't preempt it yet, because of course the discussions are going on in Rome. But that being the case, I think you'll see that featuring very much in that. And with building on the financial stability board that was created after the global financial crisis, you're going to see, I think, in that where the G20 and other groups are going to be really asking countries what they're doing to invest in health as a means of promoting resilience. So watch this space.
Okay, Martin, thank you very much. We're going to have to wind up there. We've had a fascinating discussion, and we haven't gone through as many questions as we'd like to, but that's always the case when you've got so much interesting stuff to talk about. Thank you to everyone who spoke today, all our guests, all our panelists for their valuable contributions and kickstarting quite such an interesting debate about public health. Indie Sage will be back at the same time next week, so do tune in at the same time, same place. And do send in your questions before then, as we'll have a much more general program next week, and we'll hope to take as many of your questions as possible. Meanwhile, stay healthy and goodbye. Bye-bye.
Thanks all. Bye.